Good afternoon. My name is Cavazos, Dr. Cavazos, and I'm at Hampton Roads Orthopedics and Sports Medicine. This afternoon we're going to do a couple of small things. We're going to do some anatomy on the shoulder, which is critical to understanding a lot of the diagnoses that happen in the shoulder, specifically to the rotator cuff in the older population. We're looking at a slide that shows bony anatomy. So this anatomy has to move. Just think about it as though golf ball and a tee turned on its side, and it has a lot of motion, has a lot of freedom of motion. So you need some soft tissue structures to move this shoulder about. This is an important slide because what it does is identify the four rotator cuff muscles that comprise the rotator cuff. The one that you have to remember, the lead horse, is called the supraspinatus tendon, and it is the one that's on the top of the shoulder, and that inserts right about here in my shoulder. Just remember, supraspinatus, it's the lead horse. It's the one that's almost always torn when you get a rotator cuff tear. Now, this is a slide to show you that sometimes the biceps tendon is really the real culprit. It's the one that's really screaming for help. But a biceps tendonitis in an older patient is hardly ever an isolated structure. If you look at the other starred structures, it's the labrum that surrounds the cup of the shoulder. So as you look at this picture, to the right is the front of the shoulder, and to the back is the left of the shoulder. Okay? And then you can see the supraspinatus tendon coming over the top. The biceps tendon is important. Okay? Biceps tendonitis, rotator cuff. Think supraspinatus, that's the one that's going to be torn because that's the guy who's on top. Now, these are the different shoulder layers, and you can see as you progress from the top of the shoulder down to the bottom of the shoulder or deep inside the shoulder, each layer has a different diagnosis. So just remember, supraspinatus tendon, it exits and it attaches to the humerus at the corner of the shoulder. So if you're thinking about the corner of the shoulder, just beneath that you can see there's a bursa. So you're going to get bursitis. Remember, in Latin, itis means inflammation. So you get bursitis. You go one more, then the deeper layer to that is the rotator cuff. That's the focus of today's talk. Those are typically torn. But yes, you can get a biceps rotator cuff tendonitis. Next one is the joint capsule. What happens to the joint capsule and how it gets damaged is it becomes contracted and you get a frozen shoulder, which is a common diagnosis that people know, in the general population, a frozen shoulder. And then finally the biceps tendon. And you can see the biceps tendon, again, coming up in close proximity, very, very close to that supraspinatus tendon. And then, again, you can progress back out the shoulder. But the corner of the shoulder, supraspinatus, so far, that kind of orients where you are, and that's right there on your shoulder. So let's talk about impingement syndrome. Impingement syndrome obviously is impingement when two pieces of bone come together. Which two pieces of bone? The corner of the shoulder and the greater tuberosity, which is a bony prominence on the humerus. Okay? When you bring your arm in this position or you bring your arm up in this position, you're bringing that greater tuberosity underneath the corner of your shoulder and you're pinching the supraspinatus tendon, perhaps even the infraspinatus tendon, causing you impingement syndrome. You inject it. The injection will get rid of the bursa. It's an anti-inflammatory medicine. It will not take care of the pain from rotator cuff. So if you go to your doctor and inject your shoulder and the pain doesn't go away, you're in trouble. You're worth thinking rotator cuff. MRI. What is a rotator cuff tear? Where you can see that it's, again, at the corner of the shoulder. And most of the times, a patient will come in, and what really brings them in is the nighttime pain. They can pretty much cope with it during the day, but when it gets to be the nighttime, they said, this is going to be too much, and they cannot sleep. Then the range of motion, when you try and work above the level of your clavicle, which is this bone right here, it becomes painful because now you're pinching that rotator cuff against the corner of your shoulder. Okay? And you try and do things that say, well, I don't really want this to be painful. So now you start changing the way you do business. So now you become dysfunctional, nighttime pain, can't work overhead. Now you're limited. Something's going on, and you're not sure what it is. But if you listen to this talk, you're going to think rotator cuff. So let's talk about a partial thickness. Sometimes they can respond to conservative therapy. If they're a low percentage, say 20, 30, 40%, you can get away with that. Okay, but we need to get it strengthened. We need to get it stronger. What do you mean by that? Well, these muscles are coming from your body over the head. So when that tendon, if you can imagine, if it's attaching right there, and that muscle shortens, it's going to push the head down. So if it pushes the head down, makes it strong, then it doesn't impinge anymore. So you can avoid having to have major issues if you strengthen the rotator cuff. But if the pain doesn't go away, it's not an impingement syndrome. rotator cuff tear. What about the more chronic tears? Okay, as things move along, these small tears do progress. And that's why they're called chronic tears, because then they become full thickness tears. Full thickness tears are not something you want to mess around with. You wouldn't know that if you're at home, but if you come in and see one of us, then of course we're going to get an MRI and we're going to investigate. But think, you come in, you can make the diagnosis yourself. You can say, Dr. Cavazos, I have a rotator cuff tear, I just need to get an MRI to confirm it. Why? Because you have difficulty working overhead, you got pain in the corner of your shoulder, maybe a little bit of biceps tendonitis, and you can't sleep at night. Okay? Rotator cuff tear becomes a problem. So when you start having to change the way you do business, that really interferes. And remember, as we get older, one of the most important things is we want to keep our independence. To stay independent, you need good shoulders. So, chronic rotator cuff tears almost always need surgery. Maybe not right away, but soon thereafter. And there's always, the bigger the tear, you're going to re-tear. So get to it soon. The biggest complication from a rotator cuff tear is something called rotator cuff arthropathy. Rotator cuff arthropathy is when that ball, that humerus, escapes because it's no longer kept down by the rotator cuff. It migrates north and it starts to rub underneath the acromion, the corner of the shoulder. That's a very, very painful phenomenon. So now you have rubbing pain, you're weak, you develop pseudoparalysis. Now you need a shoulder replacement. That is an arthroscopic view of a rotator cuff tear. And you can see on the right side of the picture where that tendon goes, and those arrows are where we are trying to pull that tendon back down and fix it down to the bone. If we didn't fix this fella right here, probably within a year or so, this person would have had a shoulder replacement. But to fix that tendon and save his shoulder function is a far better way to proceed through life than to get a reverse total shoulder. Reverse total shoulder. That's the topic of another conversation at another time. Just remember, supraspinatus tear, and this is the corner of the shoulder, pain. Thank you for your time for viewing this commercial, so to speak, but actually it's a talk that I want you to understand. Supraspinatus rotator cuff tear needs to be fixed. Don't avoid them. Thank you. Have a good day.